Hi, everybody. Nice to talk to you. My name is Rebecca Karp Leaf, and I am a hematologist at Mass General in Boston. And today I will be talking about the acute hepatic porphyria power study. So thank you for being here. Here are my disclosures. So let's just talk about acute hepatic porphyria. So as you know, AHP, or acute hepatic porphyria, is a group of rare genetic diseases that affect heme production. And current preventative treatment strategies include trigger avoidance, ovulatory suppression in women, IV glucose, and IV hemin. And gavocerin, which is an RNAi against ALAS1, was shown in the ENVISION trial to reduce attack rate, and it was approved in the US in 2019. But apart from attacks, AHP is also associated with poor quality of life. There's a negative impact on social and financial health, employment and personal relationships, feelings of isolation. And we really have an incomplete understanding of how AHP affects emotional, mental, and physical health in patients across the world. So the goal of the POWER study was to evaluate quality of life in patients with AHP across the globe and the impact of attack rate and preventative strategies on quality of life. So this was the publication for the POWER study, and it was published about a year ago in September 2022. So here are the methods. So adult patients with AHP were recruited from the US, Italy, Spain, Australia, Mexico, and Brazil, who have had greater than one porphyria attack within the last 2 years, or who are receiving IV hemin and/or glucose for attack prevention. The study compares patients who are receiving and not receiving preventative treatments, again, defined as routine hemin, routine intravenous glucose, and/or gonadotropin-releasing hormone agonists like Lupron. The study compared patients who had sporadic attacks, so less than 3 per year, or recurrent attacks. And in order to get sort of a full picture of what attacks and quality of life look like outside the context of gavocerin, patients receiving gavocerin were excluded. So the study was developed with the AHP community to ensure relevance and meaningful outcomes. Following information was collected, so demographics, health characteristics. Again, we went through how many attacks patients were having, preventative treatment versus no preventative treatments, quality of life questions, and then there were standardized surveys, so a depression survey, an anxiety survey, and a pain survey. And here's the PHQ-8 and the GAD-7 scales, which measure depression and anxiety, and the WHY-MPI, which is a pain assessment. And patients were asked to fill this out as well. And here are the baseline characteristics. So mean age was about 41. 90% of patients were female. About 74% had a diagnosis of acute intermittent porphyria. The mean time to diagnosis was 6.4 years. Preventative therapy use, about 38% of patients used preventative therapy. And AHP attacks in the past 2 years, the median for that was about 4.5. So pretty representative of, the patients that I see in clinic. So here are the results. And I don't think they're going to be a surprise to most of you. So regardless of treatment group, most participants reported their current physical, emotional, cognitive, financial, and social health as either poor or fair. And there was no statistical difference observed between groups for all health domains. So you can see here, looking at routine prophylaxis versus no prophylaxis, and all of these various domains. So physical health, emotional, cognitive health, financial, and social. And this is looking at those health domains in patients with sporadic versus recurrent attacks. And again, in patients with both sporadic versus recurrent attacks, the majority of patients in each group reported their physical, financial, emotional, and cognitive health as poor or fair. So this question looked at the most burdensome symptoms by preventative therapy. So again, whether or not patients were receiving prophylaxis or no prophylaxis. And the three most burdensome symptoms include muscle weakness, fatigue and tiredness, and pain. And muscle weakness was more commonly ranked as a high burden among those receiving preventative therapies versus those not on prophylaxis. And this again looked at most burdensome symptom by attack rate. And this included, again, muscle weakness, fatigue and tiredness, and pain. This question looked at the impact of chronic symptoms on daily activities. So patients receiving preventative therapies more often reported a severe impact of pain and fatigue or tiredness on daily activities compared with patients not receiving these therapies. And again, impact on chronic pain, muscle weakness, and fatigue and tiredness. And this looked at the impact of chronic pain on people's lives. So patients in both groups, again, those on prophylaxis or no prophylaxis, reported substantial impact of pain in multiple domains. And pain severity was higher in those patients on preventative treatments. And then finally, we looked at mental health, or the study investigators looked at mental health by preventative treatments. So there was a high mean depression and anxiety score reported by patients receiving and not receiving preventative therapies, respectively. And among patients receiving prophylaxis, 60% had moderate or severe depression and 46% had moderate or severe anxiety. And again, these were measured on those scales, this PHQ-8 scale and the GAD-7 scale, looking at depression and anxiety, these validated measures. And then this was mental health by attack rate. So a majority of patients in the sporadic and recurrent attack groups reported moderate to severe depression and moderate to severe anxiety. Again, this is sporadic and this is recurrent. So what are the take-home points of power? And I just want to say that I don't think that this is, again, a surprise to any of you listening. We hear from our patients all day about the impact of AHP on their quality of life. But it is so critically important to document this, to validate this. And these answers, these questions really can help guide us in terms of future studies and future thinking about how to improve quality of life in patients with AHP. So AHP severely impacts multiple quality of life domains. We talked about that. Quality of life is affected in patients with frequent attacks and those with sporadic symptoms. Chronic symptoms include pain, and that severely impacts patients' lives. Patients with AHP report high levels of moderate to severe depression and anxiety. Almost 90% of patients had to modify their personal life goals because of AHP. And approximately half of patients strongly agreed that AHP pushed them to find a new sense of purpose, which I thought was interesting. And again, so what can we do here? Validate our patients and help ensure that they feel validated by every single one of their healthcare providers. Help patients develop care plans for acute attacks with their healthcare team. So instead of coming into the emergency room and the middle of the night with a severe attack and being brushed off or not taken seriously, we want doctors to write Porphyria doctors or whoever is treating you consistently to write a plan in your electronic medical record saying, when you come into the hospital, when you come into the emergency room, these are the things that should be tested and given to you for pain. We want to ensure patients have better access to pain management centers. Palliative care can be really helpful for symptom control, alternative medicine, acupuncture, guided meditation. Of course, these aren't things that are going to take away pain, but we need to provide adjuncts and possibly, some of these complementary tools as well to help at least reduce the burden of pain. Help facilitate outpatient treatment. So rather than going into the emergency room for hemin or glucose or fluids, having a plan with your doctor so you can get outpatient treatment when you need it. Reduce barriers to telehealth. It would be great if a patient lived in California and I could talk to them and do telehealth from Boston. Develop better mental health resources for patients with AHP and AHP-specific mental health tools. connect patients with financial advisors. We know that, of course, AHP can induce a true, financial burden, especially in patients who need to miss work. Funded an initiative to train nutritionists across the country in AHP. We have a lack of understanding as to what should be sort of an ideal diet, ideal ways to manage AHP at home. So finding those nutritionists and working with them to better provide care. Training initiatives for our advanced practice providers, so NPs and PAs and social workers who see patients with AHP. And update our safe and non-safe medication resources. And then finally, I want to say that one of my sort of passions in this area is women's health and AHP, and finding out and learning more about what the best contraceptive options are, how to more effectively treat patients with AHP who may have heavy menstrual bleeding, and then pregnancy and patients with AHP. So that's, again, one of the things that I'm interested in. And please email me, contact me if you have, questions or ideas or suggestions. So now I just want to acknowledge, first of all the patients that participated in this study. I was not an investigator in this study, and so I thank all of the amazing people who helped get the study off the ground and get it published. And I want to thank my colleague at MGH, Dr. Dickey, who is the co-director of the Porphyria Clinic with me. And thank you so much. It's really just an honor and a privilege to be part of this community and to talk to you all today. So thank you very much.